Next speaker is our friend Miltos, who is now in Essen. Unfortunately, he left us. He didn't like England and went to Germany. He likes it better, but he's very successful there. And I hope you showed them how to do it, Nick, Miltos. I'm really looking forward to your presentation on the surgery. Thank you.
Yeah, colleagues, I would like to thank the organizing committee for including me in this webinar. In the next few minutes, I will speak to you about the indication and techniques for surgical excision of uveal melanomas. When we speak about surgical excision, we speak actually about large tumors, and we base our therapy in this photograph. This from a publication published last year from Professor Bechragis and other colleagues from the leading oncology centers in Germany. The publication is written in English, so you can also read this. But we refer to these tumors which are higher than 7 millimeters, and what we can do then, we either do a proton beam irradiation and an adjuvant resection, or a stereotactic irradiation plus adjuvant resection, or we treat them with the iodine brachytherapy. In case of a risk of toxic tumor syndrome, we proceed with the resections as well, and these are either the endoresection or the transclera resection. And we will start with a transclera resection, which means that we remove the tumor from the outside. The indications for the transclera resection is the uveal melanoma with the largest basal diameter not exceeding 18 to 18 millimeters, which is about a quadrant of the globe, and the distance of the posterior edge of the tumor from the fovea or optic disc should be greater than 3 millimeters. We now speak about a complex surgery with in hypotensive and hypothermic general anesthesia. That's why the anesthetist has to give us the green light. How does it work? You can see here we prepare a flap of the sclera, and then we see the tumor from the outside. We cut this flap, separating the tumor from the retina, and then close it with many sutures. And now we'll show you a video how it looks like. Here you can see a patient where we did the surgery in December. If a muscle is over the tumor, we need to remove the muscle, find the vortex veins, cauterize them, mark the tumor with the marker here, and then cut the edges, the anterior edges of the around, then preparing the flap. You can see here a ciliary artery and a ciliary nerve. We will cauterize the artery in order to reduce the bleeding. Afterwards, we always perform an anterior vitrectomy to have the eye hypotonic. It's much easier to prepare the flap when the eye is hypotonic. In the posterior part, this is another vortex vein, and then we start cutting the tumor actually all the way around the inner flap of the tumor, and you can see we will go 360 and then start separating the choroid, the normal choroid, the tumor here from the retina. This is the retina, what you can see here, and of course we will go 360 and then separate the tumor, remove the tumor very carefully, and what you see here is the retina actually, and the hair palm of the patient, and then we close the flap with many sutures. Now, this is the patient 4 weeks after the surgery. You can see here a little bit of retinal detachment here with subretinal blood, but the posterior pole is actually very good. This is our scheme, how we follow up the patients after uveal melanoma treatment. We normally check the patients every 3 months, but when we are talking about resections, then we don't stick to the protocol. Most common complications are choroidal and vitreous hemorrhages following transclera resection. This many times happens in theater, so you can see here on the left side the photograph from the theater from this patient. You can see the red reflex which is gone afterwards at the end of the surgery. So these patients need to follow up on the ward. You can see here the ultrasound, where you can actually say what is the retina, what is blood. You can suppose that here is the retina and this is a blood clot, and this one, and over the retina as well. So this is the second surgery. Then we need to proceed with a second surgery with these patients during in-stay. And after doing the phaco, you go into the eye with a vitrectomy, and you can recognize where is the retina. Is this the retina over there, or is this a blood clot? But after many time, and you will find the retina, and you can see here the posterior pole of the tumor as well. Here is the fovea. You laser everything all the way around and put silicone oil into the eye. And this is how it looks like a couple of weeks on the right side, a couple of months following the surgery. Here you can see a detached retina and a pretty good result for such a surgery. Not all patients will need a second surgery, such as this one here, where you can see a very good result after 6 days, just 6 days following surgery. There's another patient we treated last week. We removed a tumor, and then there was hyphema and a retinal detachment. So we proceed a couple of weeks later with the second surgery, and you can see here, after doing the phaco, we proceed with removing the vitreous. Here is the infiltration of the vitreous of the retina, as well, working subretinally to remove the subretinal blood, and then proceed actually with heavy liquid, laser all the way around, and silicone oil. And this was the tumor we removed from this eye, and that's how it looks like a couple of weeks afterwards. So sorry, this 2 days following the second surgery with an attached retina. And we will move then to the following up. We will always follow up these patients to exclude a recurrence and further complications. You can see here a tumor which is based to the inferior nasal part of the eye. The tumor was excised, and then there was a pigmentation on the side of the tumor, but on the other side of the tumor as well. This was a recurrence, and the eye had to be removed. But not all the patients will get a recurrence or a second surgery. You can see here in all of the results are pretty good, also with a very good visual acuity sometimes. Or here you can see a patient who didn't need a second surgery. This is a blood clot under the retina 1 year, but still with a radiation-induced maculopathy. And then we will move to the endoresection, which is the removal of the tumor from the inside. The thickness is not that relevant, because we are going to remove the tumor through a pars plana vitrectomy, but the largest basal diameter of the tumor should not exceed 16 to 18 millimeters, and the distance of the tumor to the optic disc and the fovea are relative. As we can go up to the disc, and we can also remove tumors very close to the macula. How does it work? Pars plana vitrectomy, removing the vitreous, start removing the tumor, start separating the tumor from the retina. Then proceed with heavy liquid, laser everything around, and put silicone oil inside. Another point I would like to address here is the PAVE, which was already published from Morris and 2013. If you've got your infusion cannula under the choroid, then air could live through the vortex veins and come into the systemic circulation and the patient could die. What we actually have during the endo resection is that we lose heavy liquid over the vortex veins. After many discussions with many colleagues, with Professor Hyman as well from Liverpool, we decided to cauterize all the vortex veins, as you've seen in the video, the vortex veins that come away from the tumor, and since then we don't have any loss of heavy liquid. We also close follow up these patients during in-stay. You can see here early complications, silicone oil in the anterior chamber or hyphema, or retinal detachments or choroidal detachments. You can see here the choroidal detachment. We will wait for a couple of weeks. If it persists, then we will proceed with a second surgery and cut the choroid here, relaxing choroidectomy with pretty good results actually following the silicone oil removal. As I already mentioned, silicone oil in the anterior chamber. This phakic patient will do a phaco surgery also by all our patients before the endo resection. Hyphema will come up with 11% of our patients, retinal detachment as well, but still in 70% of our patients we will be able to remove the silicone oil. We also here need to exclude a recurrence. As you can see here on the top, after the endo resection, the tumor grows towards the optic disc. This was successfully treated with 2 times TTT. Smaller recurrences can be treated with TTT. Large ones would need a brachytherapy, or in this case, as you can see, the tumor grows all around the optic disc, and enucleation will be needed. Radiation-induced maculopathy or radiation-induced optic neuropathy are late complications and may come up in 40% of our patients. But still, the results are pretty good. You can see here a very large tumor, 10.4 millimeters in thickness, 15 months following surgery, attached retina, and here a young patient 8 years afterwards with a very good visual acuity. Or here another 10 millimeter tumor on the left side following surgery and removal of silicone oil, or on the right side following surgery and removing the silicone oil, but still with radiation-induced maculopathy. To summarize, surgical resections, either the Transclera resection or the endo resection, offer very good local tumor control rates. As well as eyeball salvage rates are very high. We never should forget that these tumors are very large, and the only treatment, the other treatment would be to remove the removal of the eye. So we save the eyes in 80 and 95%. These resections should be done in specialized centers. The indication for a local resection should be made individually. We always combine these surgeries, either adjuvant or neoadjuvant, with radiation therapy. And as I mentioned before, local resections offer high eyeball salvage and high tumor control rates. Thank you very much for your attention.
Thank you very much, Miltos. That was an excellent presentation. Just a quick comment to the PAVE syndrome. So you can get air embolism with this surgery if you don't look after the vortex veins. And actually, there was a case published here in the UK last year with heavy liquid only. So you cannot prevent that by not using air. You can get it with heavy liquid as well. And this is why, exactly as you said, we would recommend in the area and wide area of the endoresection specimen, we would recommend to look at the vortex veins and cut them. This is no negative advantage of it on the surgery. So Miltos, one question, sometimes you have tumors in between endoresection, exoresection. What would be your choice if you could do both?
Depends on the ciliary body. So if we've got ciliary body involvement, then we'll proceed with an exoresection, with a transcleral resection. In our hands, when we do an endoresection with ciliary body contact of the tumor, you can just remove the ciliary body, because then you need to remove the the zonules, and then the lens will be instable, and we already experienced this, that the lens actually goes into the vitreous. So for us, it is ciliary body involvement, then transclera resection without ciliary body involvement, then endo resection.
And for the endo resection, do you do special anesthesia as well, or do you leave the blood pressure just as normal?
No. In essence, we just do a normal anesthesia.
And I think quite rightly, I fully agree with you that you need some type of radiotherapy before or after. Can you quickly comment on that? What's your favorite regarding this?
So we perform it before. Either with we don't do any proton beam irradiation before the surgery. We prefer the stereotactic or the gamma knife, just single shot 22 gray, and then we a couple of days or 1 week later we perform the resection.
And have you seen any kind of seeding along the ports with endoresection?
No.
That no, or into the anterior chamber or something like that, local seeding? Very good, very interesting.
Of course, you know, it is the one who does the endo resection has already experienced it. So when you cut into the tumors, you've got thousands of cells going around. That's why we changed our opinion, and now we do all the radiation before the endo resection. Okay,
very good.
This discussion with Lyndon da Cruz a few weeks ago, who actually reported in a meeting in Athens on some fatalities, I think 2 cases from London, and that after endoresection with not with perfluorodecaline but with octalin, I think. So the question is the ability of the heavy liquid to become vaporized within the blood system. And I mean, I haven't had many patients that have lost perfluorodecaline somewhere, probably in the circulation, but I truly never had this problem. And but I've never used hexalin or octalin. So I am curious whether this is the main issue, that if you have decalin, this vaporization within the heating within the circulation is not that significant as compared to the octalin. Do you have any comments on that?
Yeah, as far as I understand, there was 1 case in London, but there were 2 cases in Thailand, basically with the same and about to be published. I know of more cases that was conference talk, so I can't really talk about it, but other colleagues have said that the same, that they had embolism without any air and using just sort of heavy liquid. Would be interesting to see if it's all the same brand of, as far as I understand, and the London group has put in a massive amount of really work into this to look really at everything. My argument always before was, you know, I was really complacent about it and said, if you lose heavy liquid has been used as a plasma expander, infused into your veins, basically. But they said, no, not all the heavy liquid is the same. Some of them you can, and some are just impure and do exactly that. And that's the problem about it. So I think that's very important, and we work all this up. The second thought I have on this, it's probably depending also on the pressure and the time you have the heavy liquid in there. So as you know, one of the big problems of the surgery can be, it can bleed a lot, and you have to do a hemorrhage control here, there, everywhere. And we would advise to do that all under fluid and not under heavy liquid, because you sometimes have pressures of 80 or 100, and then you push out the heavy liquid. So we only use it after all the blood has stopped, and then at the very end, before we put silicone oil in, we use heavy liquid for about 5 minutes or so, not longer than that.
But I think a very interesting issue is that what Miltos mentioned, that we have never seen egress of heavy liquid after cauterization and cutting the vortex veins. Yeah. We started with this about half a year ago, and I think it would be interesting to try to analyze these cases, although it needs a lot of effort to find out how many heavy liquid vials we used in the past. Probably we will be able to find it out, and maybe we should join forces on that issue. I think
to me, it's the logical step, because if you cauterize them and you don't need them at all, really, then it cannot go in the circulation. Okay, do you